I'm Judith Trotman from Concord Hospital at the University of Sydney here in Sydney, Australia. And it was my real pleasure to watch the absolutely clear presentation by Karima Amidour on behalf of the HOVON Group and the European Consortium for Waldenström's present the Ixazomib, rituximab and dexamethasone study in about 60 patients with relapsed refractory Waldenström's macroglobulinemia. Now, we all know there's a very good rationale for the use of proteasome inhibitors in WM, given that the MYD88 mutations drive the NF-kappa beta activation via proteasome activation. But the drawback of using the parenteral proteasome inhibitors in the past has been the significant peripheral neuropathy. So the use of Ixazomib offers a potential to minimize that particular toxicity. And the other thing I liked about this trial is that they had a run-in for the first 2 cycles with Ixazomib and dexamethasone in combination and withheld subcutaneous rituximab until after the first 2 cycles to avoid an IgM flare, and also hypothesizing that they were going to minimize the number of the incidence of those severe hypersensitivity reactions to rituximab that patients with Waldenström's are so well known for. And this was initially a phase 1 and very quickly a phase 2 study when they worked out that 4 milligrams weekly of Ixazomib was very well tolerated. And it was given to about 60 patients with the primary endpoint of this phase 2 study just being a response rate, an overall response rate, which they obtained in about 70% of patients without any major toxicities. And importantly, it was gratifying to see that there was only minor grade 1 peripheral neuropathy in a minority of the patients. Of the 70-odd% response rate, about 46% of patients got a partial response, and indeed 15% got a very good partial response. And unlike the use of the BTK inhibitors, what was gratifying in this study was to see a substantial reduction in the bone marrow burden and the MYD88 mutation burden in these patients. And also to get a suggestion that the response rates appeared to be quite good in the 12% of patients, so only a very small minority who were CXCR4 mutated, offering a potential therapeutic option for this patient population who may not do as well with the BTK inhibitors. We just have to watch this space. So there's only 2 years of follow-up in this study, despite the fact it was called a final analysis. And their 24-month progression-free survival was 56%, with 60% of patients still responding and an 88% overall survival. There were no toxicity-related deaths due to the Ixazomib or the therapy. Most of the patients who had adverse events had the adverse, the expected infectious toxicities that are well known for patients with Waldenström's. So, I really commend the European Consortium in conducting this study. 60 patients with this rare malignancy is very big cohort to enroll patients into, in particular in the BTK environment now. It was equally gratifying to see that patients' IgM and hemoglobin changes, were mirrored with the IgM coming down and the hemoglobin going up, along with improvements in patients' quality of life and reduction in their fatigue. So to sort of summarize this study, I think Ixazomib is definitely able to be delivered safely in this patient population. It was a very feasible protocol with the subcutaneous rituximab, and there was no particular safety concern. I think longer term, we really want to see how well that duration of response lasts for. But I think the European Consortium have given us a backbone for trialling these agents in combination with either BTK inhibitors or venetoclax to try and advance things further for patients with Waldenström's.